Let's talk about RPM and RTM. This is the one that I think at ThoroughCare we're most excited about. Let's look at what RPM and RTM look like as of today. So if you were to do these programs in December of 2025, both RPM and RTM have different sets of codes. You have a setup and education code. So when you give that device, that initial time you spend with the patient, then there's a minutes code per month. This is clinical time per month. The bar is set at 20 minutes. That's the minimum threshold allowed. And then there's additional 20 minutes if you so choose to go over. And then there's a device code as well for each of the programs. So this is for supplying the patient with a device and the patient hitting a certain number of readings per month. And this has always been at 16 days of readings. And as of this moment in time, it's 16 days of readings. So let's look into 2026, what we could expect. This is a big change. There's now a 10-minute threshold instead of it being 20. So if you only get 10 to 19, you can bill 99470 on the RPM side. And on the RTM side, you could bill 98979, which is the 10-minute version of RTM. You will notice that it pays less, right? It's less half the time as the 20-minute code, but it still pays $26. There's also a monitoring code. And remember, I said previously the threshold was 16 days of readings. There's now a new code for 2 to 15 days of readings. So if you fall less than 16 and you're in that 2 to 15 period, you can take advantage of that for both RPM and RTM. Now, I will note that both the 2 to 15 day of reading code and the 16 day of readings code pays the exact same thing, 47.43 national average. So we thought it would probably be less. It looks like CMS chose to make them the same. So Kathryn, I got to ask, what are they thinking? Or is this a good thing? Or is this just encouraging them to have more utilization, or maybe allow the provider and care team to find the right metric for each patient?
I love exactly where your head's at. I couldn't agree more. I think what we're seeing with these codes are really having an easier time for providers and patients, having an easier time to actually meet the CPT code requirements. So with that, organizations now face, or they will face, a lower operational risk when they launch or scale an RPM program, especially in those early stages of patient engagement. Having this added flexibility allows care teams, as you mentioned, to really tailor monitoring to what the actual clinical needs are. Not every patient needs a 16 readings in a month or 30. So there's more flexibility in that now providers can have a program that supports short-term or episodic monitoring. Maybe we're titrating a medication. And this really helps ensure patients aren't forced into a one-size-fits-all type of model. I'm viewing this as a strength.
I agree. My one worry, though, is that I hope people don't take this as CMS is lowering the bar and that it's acceptable to give a glucometer to a patient and say, take your reading twice a month. And that's really not the case. But the government, flat out said we're going to continue targeting fraud, waste, and abuse, and to expect more scrutiny. And I just hope that you don't take away from our webinar that you're telling your patients to take 2 days of readings, because it really should be tailored, like Kathryn said, to their condition, to their needs. So Kathryn, I know you work with a lot of our clinics and consulting. What are some best practices for groups that, okay, you don't want to lower the bar that much, but you still want to get enough to be compliant and be able to explain it if you had to?
I'm grateful for you making my job easy, really highlighting, yes, documentation is important, more now than ever, just because there's that lower barrier for organizations to participate in RPM with more flexibility. That does not equate to a lower standard. If anything, I think that we need to be even more intentional about our use of monitoring. So CMS and auditors, they're likely to look for those patterns of minimal engagement, repeated short durations of billing, weak clinical narratives, potentially no connection between the readings and what's happening in the chart from the provider perspective as well. So high-performing programs, what we'd expect to see is clearly documenting the purpose of monitoring, I cannot express that enough. At the beginning of the program, that goes a long way. Then also really linking those readings to the clinical actions. If a reading is high, what did we end up do about that? Then ensuring that those trends and data that is reflected into the ongoing decision making about how we're managing that patient's health.